let's hurry up and get started. So for anybody that has never joined one of our Ask the Expert sessions before, my name is Megan Hansen. I am the co-founder of Recurrent Pregnancy Loss Association. We are a nonprofit organization dedicated to supporting families who have experienced multiple miscarriages, and really working to advance the understanding, work with the community of care providers to advance our understanding of this condition. So with these Instagram lives, we try to sit down with people who are really experts in treating couples that have dealt with it and ask questions from the patient perspective. And so today I'm really excited to be talking with Dr. Gregory Piazza. He is an associate professor of medicine at Harvard Medical School and faculty cardiovascular division at Brigham and Women's Hospital. Dr. Piazza received his medical degree from the University of Massachusetts Medical School and completed residency in internal medicine, general cardiology fellowship, and an advanced cardiovascular imaging fellowship at Beth Israel Medical Center in Boston. He also completed a National Heart, Lung, and Blood Institute sponsored advanced fellowship in vascular medicine at Brigham and Women's. His research interests include epidemiology, pathophysiology, diagnosis, treatment, prevention of venous thromboembolism, thrombophilia associated infertility, which is why we're interested in speaking with him, and a number of other areas, including computerized decision support to improve cardiovascular outcomes and stroke prevention. Dr. Piazza, thank you so much for agreeing to chat with me today. Thank you for being here and working through all of the crazy technology.
No problem.
I read your bio, which is so impressive, and I'm so excited to chat with you, but I'd love to just take a step back from that and ask, how did you, in studying cardiovascular medicine, how did you start to work with the infertility community and the pregnancy loss community? How did you get here?
Yeah, it's a crazy kind of stepwise process. So vascular medicine is this subfield of cardiology that focuses on any sort of vascular issue that occurs outside of the confines of the heart. So we tend to deal a lot with blood clotting and blood clotting tendencies. Things that could be inherited or things that are acquired, things like factor V Leiden, these inherited tendencies towards clotting. And what happened was, when I started off as faculty at Brigham, I would occasionally from the OBGYNs get a referral for a patient who was pregnant and had a blood clot. And then after they got to know me a little bit more, it would be patients who are pregnant and have a history of blood clot in the past. Then it would be patients who have a history of blood clot and want to get pregnant. And eventually it would be people who have a history of a clotting disorder and want to get pregnant or have infertility. So it sort of kind of went through a series of steps where the OBs got to know me at the hospital and my interest in blood clotting, and then the reproductive endocrine or infertility specialists heard about me and started, they basically didn't know who else to ask, and they would have patients that had gone through IVF cycles and still were having losses, and at that point they'd done what they could, and they were wondering if there was anyone else who could take a look at their patients and offer some more help. And so I started getting more and more referrals, and now it's up to roughly about a third of my practice.
That's incredible. So I'm of, I guess, the need and the need for somebody that is really helping in that area. Can you, just to paint the picture and the context, can you explain why blood clots, why they would negatively impact pregnancy or lead to infertility? What's the mechanism or the reasoning behind this?
Yeah, so it's interesting. There are a lot of different ways that balance and imbalance in the clotting system can impact fertility and pregnancy and even conceiving. So first of all, at its clearest, pregnancy itself is a high estrogen state. In patients who have prior blood clots or a history or tendency to make blood clots in the setting of pregnancy, where estrogen sort of increases your coagulation, they run a higher risk of developing blood clots and even potentially having pregnancy losses. But even in patients who don't have that history and outside of pregnancy, the clotting system has to be in balance even just for implantation of the fertilized egg. When the egg fertilizes and implants into the endometrium, the lining of the uterus, it initially doesn't have like a lot of blood supply, but it gets the formation of small blood vessels that help to nourish the embryo as it's developing. And a tendency towards thrombosis can lead to loss of those little blood vessels and early losses. Sometimes even chemical pregnancies may be due to a loss of sort of those important, very microscopic structures. Later on, when the embryo becomes a fetus, you have the true formation of the placenta and cord. And there, the placenta is a highly vascular structure with lots of blood vessels, same with the cord. And you can get blood clots forming behind the placenta or in the cord that can decrease blood flow and the delivery of oxygen and all the things that are necessary to the baby. And so that's where we see losses later on down the line. These tendencies towards blood clotting also, even if they don't jeopardize the pregnancy per se, they can lead to other important things like preeclampsia, or something called placental abruption, where the placenta lifts off of the uterine wall a little bit, and that can be a medical emergency. So there's a lot there when it comes to the balance. It's all balance.
Yeah. So you talked about sort of the reasons why it would be important, why it's important in like different stages of pregnancy. Is it potentially different underlying conditions or different causes of thrombophilia that might cause losses at those different stages? Or is that, I don't know.
That's a great question, because it's something that I struggle with a lot in sort of dispelling some of the myth out there. There's this, even in some of the guidelines, there's this idea that pregnancy losses due to thrombophilia are first trimester. Mm-hmm. But if you actually look at the literature in sort of as a collection, these types of thrombophilias can cause anything from just difficulty conceiving to early chemical pregnancies or first trimester losses to stillborn and other peripartum complications. Mm-hmm. So it's really, it doesn't fit with any particular time during the pregnancy, and that's a myth that we need to try to, because people don't think of sending testing unless it's a first trimester loss, but it doesn't have to be a first trimester loss.
Okay. And I guess like follow up to that, is there a way to know whether a specific loss was caused by a thrombosis related event?
That's one of the hardest things. So right now, there's really, we don't have really clear mechanisms for all of the thrombophilias and how they cause pregnancy losses. But they all have relatively, or many of them have relatively strong associations with pregnancy loss. But it is a little hard to, to figure out why. First of all, when you approach a patient who's had recurrent pregnancy loss, you want to rule out aneuploidy or abnormal genetics, because worldwide, that's the most common cause of pregnancy losses. And, when I talk to my patients about genetic losses, they can be either inherited because you carry something like cystic fibrosis or something like that, or they could be random. But if you don't, and usually infertility doctors will do testing for inherited genetic problems. If neither you or your partner carry that type of a genetic abnormality, then it's going to be a random genetic change. And random means random.
Yeah.
So if you've had 4 losses, there's nothing random about that. Or if you've had 4 failed IVF cycles, there's nothing. So that makes you think it's less likely to be genetic.
Yeah.
REI, our reproductive endocrine clinicians will also look at the GYN tract to make sure the fallopian tubes are open, egg quality is reasonable, all of these sorts of things. And once that gets ruled out, what you're left with is, the likelihood that it could be a thrombotic event. Sometimes the product of conception, if pathology looks at it, they might see blood clots, and that can be helpful. That's why I always look at, like, if there's a D&C or some other procedure, always look at what they got out, because sometimes that can be a good clue.
Okay. So, and I guess you sort of this, but so as you're going through that diagnostic process, what signs or symptoms indicate to you that somebody's losses might be related to thrombophilia? Like, are all patients appropriate for this course of investigation, or just some, and how would some?
So it's a terrific question. The first thing I look for is the pattern of infertility and losses. And really what I'm looking for, and this is going to sound crazy, but I'm looking for the absence of a pattern. Okay. That's the pattern that I'm looking for. Things that don't make sense. When things don't make sense, then I start to think about thrombophilia. And here are some of the things that don't make sense to me. Someone who has had 2 children, then they take a little bit of a break, to raise them, and then they decide they want a 3rd, and then they have a series of pregnancy losses. Thrombophilia has a lot to do with age. As we get older, we tend to be more susceptible to the complications of thrombophilias. So someone who had no problem in their 20s might have problems in their 30s. And that's a question I get from my patients all the time. Well, if I had factor V Leiden and it's a genetic thrombophilia, I had it since I was born, but I have, 2 children that I had no problem with, and now I can't get pregnant. It can be the age. Another thing I look for is success is intermixed with failures. If there's something wrong with the GYN tract, traditionally there's going to be really a number of losses until that gets fixed. Or there's going to be consistent difficulties, but the sort of sporadic failures are something that I clue into. Those are big. Family history of miscarriages, prior history of blood clots, that sort of thing makes me also very, very clued in.
Okay. And so then once you identify, hey, there might be something going on, walk me through what's the assessment you're doing, what tests that you do yourself that you would recommend that other patients, their providers about doing?
Sure. So, the way we think about it is, in general, if you look at the guidelines, the American guidelines say that after someone's had 3 pregnancy losses, you should start to think about blood clotting problems. I think that's a lot to put people through to have 3 losses. The European guidelines have become a little bit more open-minded towards this testing. It's not, it's interesting. Part of the knock against doing thrombophilia testing is the cost, but the cost pales in comparison to what a failed IVF cycle is. So it's really not, it's a few $1,000s compared to, tens of thousands of dollars. But after after 2 losses, the approach is really to look through, make sure there aren't genetic explanations for this, that the GYN tract has been looked at and seems roughly fine. And then what I start with is a panel of blood tests, some focused on inherited blood clots, blood clotting tendencies, factor V Leiden, prothrombin gene mutation, and then some acquired ones, which largely are some things called antiphospholipid antibodies. These are little proteins that your body makes against proteins on the surface of your red blood cells. People don't really know that clearly why people make them. Some of it has to do with blood type. Some of it has to do with the proteins on the surface of the red blood cells. And some think that in life, at some point, exposure to benign virus like a cold or something triggers a sort of autoimmune reaction and you develop these antibodies. But I tend to look for genetic or inherited thrombophilia and some acquired things. I also do a test called high sensitivity C-reactive protein. That is a test looking for sort of vascular inflammation.
Okay.
It's helpful in a number of ways. Having high levels of high sensitivity C-reactive protein is associated with difficulty conceiving and pregnancy loss. It's also associated with metabolic abnormalities, things like high blood sugars, hypertension, obesity, those, cholesterol issues. That becomes important too, because all of those things also need to be kind of, the body needs metabolic balance to be successful as well. So that's a clue. And finally, there are studies that show low dose aspirin can help to mitigate the impact of this kind of inflammation in the blood. So I do that, and then we see what we find, and then I'm sure you'll ask me about what we do.
Yeah, I was just saying, that was a lot of, because it's a number of different assessments. Is the treatment the same? Like what you find something, and what are the different possible treatment pathways depending on what comes back?
So it's a great question, because the treatment is the same, but the reason that it's the same for a lot of these things is because we only have a few blood thinners that you give in low doses that are safe during pregnancy. And so that's sort of why patients may hear the same thing over and over again. So if someone has a blood clotting tendency, the antiphospholipid antibodies, which there are a collection of them, that some of them are called lupus anticoagulants. They don't really have anything to do with lupus, but that's the name they got. Anticardiolipin antibodies, those sorts of things. The data are very good for using a low dose of an injectable blood thinner called Lovenox, which can increase the likelihood of conception, the likelihood of successive IVF, live birth, reduce complications of preeclampsia and abruption, and keep the mom safe. So that's the data are quite good for that, and even the guidelines say that's the right thing to do. For patients that have inherited tendencies towards thrombosis, factor V Leiden, prothrombin G mutation, or some deficiencies of proteins called protein C or protein S or antithrombin. We also use the Lovenox, this type of a low molecular weight heparin blood thinner. And there the data are, they're in general good, but not as strong as the antiphospholipid antibody data. So some people will be like, well, the data's not as strong. I don't know if I should do that or not. But in general, a lot of people that do this will prescribe that. And that also has been shown to help. For patients with signs of inflammation in the blood, we add aspirin. We give aspirin. If they have no other tendency towards clotting, then it's aspirin alone, a baby aspirin. If they also have something like an antiphospholipid antibody and the increased C-reactive protein, then we combine that with aspirin, the low molecular weight heparin.
Okay. Are there, what are the, I guess the question is like, what are there risks of pregnancy or a person that's taking, or the Lovenox, I should say? Are there any, is there a reason to give that everybody empirically?
Yeah. So that, one would wonder, is there a reason to, well, I think, first of all, it's an injection. The reason that it's an injection is that it's a large molecule that can't be absorbed through your GI tract. So that's annoying for moms to have to do injections really for the length of the pregnancy.
Yeah.
But when you tell the mom that by the same token, because it's such a big molecule, it doesn't get to the baby's bloodstream, and so there's not that risk of birth defects, they like that. So it is safe. It is safe for the pregnancy. We've used it to treat blood clots in pregnancy for decades. These are not experimental medications. We've used them. We have a broad experience with them. In most patients, we use the same dose to prevent blood clots in patients who are undergoing surgery, and we don't see really major bleeding with it. And the studies have shown that it doesn't seem to increase the risk of bleeding for the mom during pregnancy. That said, do we occasionally see some bleeding? Sometimes, mostly around the injection site, like bruises and bumps. So that's a reason why we wouldn't give it to everybody, because those bruises and bumps can be a nuisance, and we don't want to cause any harm, even little harm, if we don't have a good reason to. But it is otherwise a very standard therapy and well tolerated.
And do you know there? My own experience, I different doctors think of it started at different points in the cycle when trying to conceive or getting. What's your perspective in terms of when to start those regimens?
Yeah. So again, I go back to sort of the pattern. If patients are having difficulty conceiving, then I want to start it with ovulation, because it's amazing all of the processes that get started just right after conception. I mean, all of this vasculature, all of these vascular changes start happening. And so you want to make sure that the tendency towards blood clotting doesn't start impacting that before the patient even knows they're pregnant.
Yeah.
So I like to do it with ovulation, and I'm a big fan of doing either ovulation kits or apps, something to know when we should start. If the patient's undergoing IVF, I like to start with the beginning of whatever their cycle is going to be. So whatever medication, a lot of these medications that are given to start a cycle affect hormones and can increase the tendency to clot. So I like to get in before that, 5 minutes before, a day before, but just before.
Yeah.
If there's not been a problem conceiving, then in that case, I will do it with a positive pregnancy test.
Okay.
But in general, for me, I like to start it as early as I can.
Yeah. No, that's interesting. Hearing. So I have a question. We talked about how you got into this space and types of patients. So you're a cardiovascular specialist. My personal experience when I was going through the diagnostic process, I was a rheumatologist. Antiphospholipid syndrome is an autoimmune. Like for people that are trying to figure out how to navigate this and who they should talk to, what are your recommendations? Are these things that an OB or fertility specialist could just as easily look at, or should people be looking out a different level of specialty?
Yeah, no, that's one of the biggest challenges, I think, because this part of thrombosis and blood clotting tendencies or thrombophilias in different centers are cared for by different people. And so there's not a specialty that's going to be universally sort of helpful for this. I think that OBs in general may not know as much about this. Infertility specialists will know to varying degrees. Mm-hmm. And even at my center, there are some that are very keen on this and very focused. And when I get patients, they've sent most of the labs. And there are others that just don't think that this is that important. Mm-hmm. But in general, the types of doctors that will sort of take care of this include reproductive endocrine or infertility specialists, vascular or thrombosis specialists, and then hematologists. The reason I exist is because by and large, hematology in my network has not been particularly interested in this area.
Got it. So, for people that are either because they're not in an urban area or don't maybe have access to fertility specialists go through this, are there resources or other things that you can meet couples to get to their OB and say, this is what's going on with me, or this is, are there any resources that we can point people to learn more or help their physicians learn more?
Yeah, so I wish there were more resources, to be honest, but some of the things that I think are good to, I work with a nonprofit organization called the North American Thrombosis Forum, and there's some information on that website, because I've given some patient and provider education sort of symposia on this particular topic. There are some nice, I think the European guidelines, even though it's a slog to read these like
Yeah.
100 page, there are summary documents for them. The European guidelines, a lot of the research on this comes from Europe. And so the guidelines are a little bit more advanced, a little bit more open-minded to this. And so they're a good resource for clinicians to look at. It's the European Society for Human Reproductive Endocrinology. That's a good place to start. The American guidelines have not been updated that recently on this, and so it gets to be a little bit, they don't reflect some of the latest literature. But your infertility specialist will be a good resource. I think my sense is once patients get to an infertility specialist, the ball starts rolling, and at least this gets talked about. What I think, and not always, of course, not always, but I think when patients aren't referred to an infertility specialist and they've had already like multiple pregnancy losses, that's where I feel like there's a huge gap. No one should go through that alone without the help of a specialist. One, I can understand, but once it's more than that, you really you want to intervene on this process that's so taxing psychologically, emotionally. It's so tough on the couples. The more you can reduce that trauma by intervening early, I think that's the whole point of what I do, is to try to see what I can do to reduce this from happening again.
Yeah, no, I think that's I think that's a huge point, is just that if this is happening multiple times, if it's happening, like every feel comfortable asking for additional assessment.
Yeah.
Not random. Yeah.
For the fertility specialists, they're to their credit, they don't give up. They're head down, trying different things with the different cycles. And so, a lot of times having an outside perspective like I do, I kind of think that being an outsider on all of this in a way is helpful, because I take a step back and, rather than looking at how I'm going to change the next cycle, I look to see, are we missing sort of, some other systematic issue here that we can help with?
So you mentioned the U.S. guidelines and haven't been updated in a while, and they do talk about I think the assessment for antiphospholipid syndrome, not so much the inherited thrombophilia. I guess, why do you think that is, and do you think that do you see that changing in the future?
So it's really because the bar of expectation for these things is very high. So for antiphospholipid antibodies, there are more sort of high level studies, randomized controlled trials that sort of have shown enough of a difference where people feel like, yes, this makes sense. With some of the inherited thrombophilias, the studies are smaller. They're from Europe. They may not be randomized. And so if you're going to draw your line in the sand and say, I only want the highest level of data, then you're not going to be able to necessarily help patients with these inherited thrombophilias or less common things. But you want to help them. And so you have to be open-minded and look more at the study and say, okay, I understand this is non-randomized, but were things done in a way that, represents my patient? And there's a big call in the literature right now by a lot of really the open-minded folks in this space that say, we're not doing a service to our patients by stomping our feet and demanding large randomized controlled trials. This population is sometimes hard to study. Enrolling patients in these types of trials has traditionally been challenging and slow. And so we have to be more flexible in what we're asking. And if the intervention's safe, maybe we have to give it a little bit more of a benefit of the doubt. And so there is a push for that. There's a push for alternative study designs that are much easier to execute. So sort of observational studies or studies that try to correct for some of the biases in observational studies, so that the data seem more real. And I think we are getting there. There's a lot more. I work with a group in Italy, and we've been advocates of this. And I think, I see a bit of a change. The European guidelines are certainly a change in the right direction.
Yeah. So Dr. Piazza, you are actively researching it. Where are the biggest areas that you're excited about that you think like new findings or new learnings are coming? And on the other side, where are the biggest unanswered questions in your opinion?
Yeah. So the research right now is really focused on understanding sort of how common these blood clotting tendencies are. And that's something we're working on. We're also trying to get a sense if there are certain types of patients that respond better to the low molecular weight heparin, the Lovenox therapies or the aspirin therapies. There's a nice big trial underway looking at the inherited thrombophilias in low molecular weight heparin, a randomized controlled trial called ALIFE-2, is a European study. We're all very much looking forward to those data because that could be really helpful if it's successful at clearing the air on the inherited thrombophilia. So I'm very excited about that. Some of the biggest question that's still always out there is, what is the mechanism by which these things cause recurrent pregnancy? I mean, we have theories about what happens. There are nice diagrams that go through all of the potential changes, but what's the causation? That's something we still need to understand. We're gaining more tests, see, the interesting thing, Megan, is that there are hundreds of thousands of genes or even more that regulate clotting, and we have like 12 tests. Yeah. So when a patient tests negative, it's not that we're saying you have no problem, we just couldn't find one. Yeah. So that as we get more of those tests, that's getting helpful. And even just in the last year, we've gotten access to a little bit more. But I think that these trials are going to be really important. The ones looking at the low molecular weight heparins, the antiphospholipid antibody stuff. We've traditionally used blood thinners for that. Yeah. But you're right. You mentioned it's an autoimmune thing. It is. And people are starting to look at some anti-inflammatory or inflammatory modulation to help those women. In the past, people would use steroids, but that's a shotgun, to try to hit a small problem. You want to be a little bit more refined so you don't give people side effects. And there are people looking at that. There are some studies looking at, remember hydroxychloroquine that people were super excited about for COVID? They're actually, there's some, first of all, it's safe in pregnancy. They used it for treatment of lupus in pregnancy for ages. It's something that people are looking at for treating refractory antiphospholipid syndrome causing pregnancy losses. So, we're sort of a very young field in a way. I mean, we've known about this for a long time, but the research money and everything, the studies have not been there until recently. But we're getting there.
Yeah. I just saw this up, and thank you for those of you that have been submitting questions. I apologize if I can't get to them all because we try to field them sometimes in a. The one that just came up, it leads right into the conversation we were talking about. If somebody is taking blood thinners, they're on low dose aspirin, they're using Lovenox, and they're continuing to have pregnancy losses. Do you do that treatment? Where do you think it goes next in the sort of diet pathway?
Yeah, that's a fantastic question, and it comes up, with some, it's kind of it's not rare. So the first thing is to look back at all the data again. If you've had someone who's been doing Lovenox and they've had more losses on it, let's say it's been a pre-implantation genetic tested euploid embryo and it's still, then you really have to ask, what am I missing here? There is such a thing as sort of immune rejection of, you know, that's a very rare cause of infertility, but it can happen. The things I think about, if someone fails Lovenox multiple times and I know they have a thrombophilia, I will sometimes add aspirin, because there are some data that suggest platelets do have a role in this. There have been some studies that show that, first of all, that aspirin helps with infertility, but also that abnormalities on some of the proteins on platelets can actually lead to infertility and pregnancy loss. So I'll do that. If Lovenox doesn't work, if aspirin added on doesn't work, then you have to wonder, is Lovenox the right medication? There are other things we can try that are safe in pregnancy that may be a little bit more potent. But before I do that, I want to make sure we're not missing something else. And that's usually when I'll go back to the infertility specialist and say, you know, let's take another look. You know, is there a thyroid issue that we're missing? You know, is there chronic endometritis or some other inflammatory or infectious problem that we just, you know, maybe it wasn't there back before, but maybe it's popped up since.
Yeah. No, thank you for. I also wanted to, you know, you've mentioned a couple times the standard tests that you look for, factor V Leiden, and I might ask you just to repeat the list so that I have it. But I also wanted you also then mentioned you're learning more and more of what possible genetic mutations lead to having a thrombophilia. What are some of those novel tests, and do you recommend any of those beyond the standard?
Yeah, so the standard that you know, most OBs and infertility specialists feel comfortable with are the antiphospholipid antibodies. So something called a lupus anticoagulant, which doesn't necessarily imply that someone has lupus, and it's not an anticoagulant. It's kind of a weird name. It's procoagulant, and there are plenty of people who don't have lupus that have it, and a lot of people with lupus don't have it. So that's one, the anticardiolipin antibodies. Mm-hmm. Most other centers will also have something called an anti-beta-2 glycoprotein 1 antibody that they can test. At our center, we have 2 more antiphospholipid antibodies that we're able to test that I found helpful: antiphosphatidylserine antibodies and antiprothrombin antibodies. And all of those have reasonably good data for them. For the inherited thrombophilias, we do factor V Leiden testing, prothrombin G mutation testing. People always ask about the MTHFR mutation, which is a gene that sort of regulates folic acid metabolism.
Yeah.
When that happens, when you have that abnormality, unless the byproduct of that is really sky high, something called the homocysteine, I don't do much with it. So there's, if the homocysteine's above 20, I think that's a problem. Okay. If it's less than 20 and there's the MTHFR mutation, the problem with the MTHFR mutation is extremely common in the US. And, you know, it's almost like saying, you know, Dr. Piazza, do you ever see recurrent pregnancy loss in women with blonde hair?
Yeah.
Like, yes, I do. And I also see it in people with the MTHFR mutation. Doesn't mean they're related.
Right.
So I don't necessarily do a lot with that test. Protein C, protein S, and antithrombin deficiencies we've seen. And in our registry, they're pretty common. So that's something important that I do. I do the C-reactive protein. Some of the newer stuff that I've been doing is, you know, in some of the literature, factor VIII levels seem to be of interest. So I'm doing it mostly because I'm trying to learn about it and see if I can understand what its risk is. The plasminogen activator inhibitor 1 mutation people will send. We actually don't have access to that, but I check levels. The problem with plasminogen activator inhibitor 1 is, like, smokers can have high levels. People with other inflammatory diseases can have high levels. So you just have to know what the patient has and, you know, take it in context.
Yeah.
So that's that. Some of the things that I've seen that people send that are kind of problematic, the plasminogen activator inhibitor 1 mutation doesn't have a tremendous amount of data. Sort of it can come out in different ways, and some people tailor what they do based on it, but I haven't found good data for that. Some people send something called an angiotensin converting enzyme mutation, the ACE gene mutation. Haven't found anything that scares people without actually giving them, and it's very common too.
Yeah.
So you really do, it's tough. In some ways, I wish that people would send these to help patients to avoid failed, costly IVF cycles and pregnancy losses. By the same token, I want people to really know which test to send and not just send everything, because some of them don't matter or don't matter a lot, and they cause other problems like concerns in patients, anxiety. And so really, I try to do it with like a very I try to weigh out, what am I doing? Why am I doing it? What am I going to do with the results before I do it, so that I'm being fair to the patient?
Yeah, no, that's a really good point. And it's like run full panels on all of our blood and it would come back with something, but that doesn't necessarily mean that,
Right.
So what, for we talked a little bit about, for the person that's watching this and they've had multiple losses, certainly ask their doctor if they haven't been referred to a fertility specialist. That might be the right first step. If they're at a fertility specialist and the doctor that they're working with is, I guess, not interested in thrombophilia or the thrombosis related pregnancy losses, what advice do you have about helping that advocate for themselves or kind of taking the next step?
Yeah, I think that there are probably two things come to mind. One is to, ask for a referral to someone who might be more comfortable with that type of disorder. It may be, a vascular thrombosis specialist should be very aware of this. Hematologists, depending on what their interests are, could be interested in this. It's just, if they deal more with hemophilias and bleeding disorders, they may not be, it's just, it's like in cardiology, there are people who do heart failure and people who do heart rhythm stuff. There's a lot of sort of sub specialization.
Sure.
The other thing is just to know what the kind of guidelines are. So the current guidelines are to start thinking about, at least from Europe, it's to start thinking about this after 2 pregnancy losses that aren't explained by aneuploidy. Or abnormal genetics or a GYN issue, and just to tell, I think a lot of the current climate of medicine now is that we like to hear, we like to have conversations and discussions with our patients. We want to be as much we could use partners, I think, in care. So we like, talk to us about, and if your infertility specialist doesn't know that much about this, say, I heard that after 2 pregnancy losses, this is something that people think about. Should we go down that alley? I think that can be really helpful. There are some resources online that maybe I could give you, Megan, for you to share with your group. I've written a patient page on sort of thrombophilia and women's health that might be helpful. And then recently, there are a couple of more sciencey articles, but not hard reads, where we talk about this too. A collaborator of mine from Italy that's just phenomenal. We wrote like a sort of case-based approach to discussing the debates in this field, and that might be a good read for some out there.
Well, yeah, and that leads me, I guess, to the kind of opposite of that question, which is to OBs or REIs that are, seeing patients that are having recurrent losses and not being able to manage it with their current box. What advice do you have for medical colleagues of yours?
Yeah, I think it's my advice to my medical colleagues is to really to be open-minded about this. To really step into the shoes of the patient. A lot of our patients come to us and they're looking for an explanation of why this keeps happening. And although they're very excited to hear that, we're going to change this cycle and do this differently, a lot of patients want a reason. And so this is one way to give that reason, and be open-minded. It's not enough. And I was just telling my fellow this today, my trainee, you know, it's never enough to just observe an abnormality and treat it. The next step is to understand why, so you can treat it more effectively or prevent it. And so asking why is what I would say my colleagues should do.
Yeah, no, absolutely. Dr. Piazza, I know we're at the end of the hour, and I had a little bit of hiccups at the beginning, but I want to be respectful. I want to thank you so much for this conversation. I will 100% share the resources on the web. I'm comfortable with that, because I think people would really appreciate it. But I thank you for discussing this topic with us, because I think this is something that comes up a lot in chat rooms and in questions and all over. So it's nice to be able to hear directly from an expert on what we should be thinking about and what's worth investing. And I'm getting lots of thank yous coming through the comments. So this was very much for everybody watching. Yes, this will be posted on our account. You can watch it later if you want to go back and hear all the tests. So don't worry, it will be posted. But I sincerely thank you.
Oh, it was a pleasure. And, you know, I think this group is so great. It's so important. I was so happy to hear about it, because it's so needed. And to have, you know, an exchange like this, this is another way that we raise the bar, right? By arming patients with knowledge, by talking about these things, by not keeping it in silence. That's one of the themes, like, of one of the pieces I wrote about how, you know, we can't just let people suffer with this in silence. You know, we need to be lights. We need to be beacons to, you know, try to, you know, dispel the darkness around this. And so that's, you'll see, I'll send you an article that's actually on that. And I think, you know, this is a step forward.
Yeah, no, thank you. That's awesome. And, you know, I'll speak for myself, but also a lot of the families that I've talked to that have gone, really does feel. And so that there are doctors like you out there really focused on trying to, is really important. So
yeah. Excellent. Well, thank you, everybody.
Yeah.
All right. Excellent. Thank you. Take care. Be safe, everybody.
Thank you.
Bye.